And I think we're all on, so I'm going to get started. My name is Dong Kim. I'm the chair of the department here. Welcome to Houston, virtually. It's a little unusual to do this year. We, look forward to having all the candidates come and visit. But we'll make the best of it. For today, we're going to start with an hour presentation, me doing part of it, and then Dr. Day about the program. And we'd like to kind of go over things with you so that you're not asking the same questions and spending time with the faculty over basic information. And we'd like to spend our interview time getting to know you. So I'm going to start sharing some slides, and we don't have too many. Okay, if you can see this okay, then just give me a thumbs up since you're all, okay, great. So our program is relatively new, as you are all probably aware. We've only been here for about 12 years, and we've grown a lot in that time. And I think it would be interesting for you to hear our history, what happened, and where we are. I want to go over with you what our goals and sense of mission are here. Since you will be mostly at the Mission Neuroscience Institute in Memorial Hermann Hospital, I want to go over that with you so you understand what that is. And then a listing of the faculty. You're going to meet most of these people, so I don't want to go over that in too much detail, but just so you have a sense. And then I'm going to finish up with kind of what my and our program sense of what we want you to learn here and what we'd like for you to get, what we hope to teach you and help you in your career. After that, Dr. Day is going to go into great detail, the details of the residency and rotations, philosophy, all of that, so you understand our program, which is quite set at this point and established, as you'll hear. And then we'll break off into individual interviews, and at that time you can ask more questions and go over, and hopefully we'll get to know each other. So I became the chair here in October 2007, and it was a very small department then with almost no education and very little research. And the whole caseload at our TMC hospital here was only 1,100 cases a year, and they were mostly emergent cases. So not a robust program. It was probably the number 4 program in Houston for neurosurgery. But I thought there was an enormous opportunity. Being with the university and the hospital had wanted to develop neurosurgery. I was relatively quite young at that time, and so the thought was, well, we can turn this into a great program, and I have the time to do it. So this is where we are now. We have, in that time, brought on 100+ faculty. We've become a multi-specialty group, all in one department, including neuroradiologists, not neuroradiologists, neuro-oncologists, radiation oncologists, pain management, and so on. We have a big research program. We've had a very, very large increase in volume. We're doing about 4,500 cases now at the TMC, and all of that increase has been in elective cases, and we have become the market share leader in Houston. And the last time we tracked neurosurgery admission data, we had 39% of the Houston market coming to our hospital, which is pretty hard to believe number in a city like this. The second largest program was at about 18%, so it's a big gap. And those are data provided by the Texas Hospital Association that you can look up online and so on. We've had very good quality outcomes, And as you will see, our education and research programs have been quite transformed. And I don't know how many of you are familiar with what an R25 program is, but I will describe that to you because that is quite a achievement. So where are we today? This is a picture that I started showing for our group in 2007. And our kind of goal was to get to the promised land. And what does that mean and how do you get there? You know, I believe that having the right goals and values and culture is the most important. And when you set that, then it's all about the people, recruiting the right people, getting people to work together, not against each other. And when that happens, the foundation for a program is dominant, high-quality clinical programs. Because in our area of medicine, you cannot teach without a high patient volume. You can't teach if you're not doing a lot of different kinds of surgery. You can't learn to do research if there isn't a great research program. And then once that happened, our goal is to be the best. And we're a team that wants to be a championship team and works toward that. So where are we now as you guys are looking at the program? I think we are in the promised land, and I think we reached most of these goals. As I said before, we're the #1 program in Houston, but we're also the largest in Texas and one of the largest nationally. I think our culture is one of a very supportive environment, but where people work hard and achieve. We have a huge education program, and I'll go over that with you in some detail. And we've been in the last 2 years one of the top NIH grant-getting neurosurgery departments in the country. There are other areas we've gotten national recognition. You know, the Vivian rankings are what's considered the most rigorous outcome rankings, and we've been in the top 10 for neurosurgery in multiple areas like mortality for 6-7 years now. We are a Walmart Center of Excellence for spine. There's only 7 academic medical centers that have this, and we just got designated PBGH Center of Excellence for Spine, which includes McKesson and JetBlue and Lowe's. So we have patients flying in from all over the country, not only for these centers of excellence, but to see our individual physicians and so on. So I'm going to go over some of these things for you so you can see some of the data behind it. And then, but before that, I want to say that for us now in the next 10 years, it's not a time of building and adding and growing and looking to the future. I think the time for us now is to mature, to do great things with the team we have. We're obviously going to keep adding people and so on. We're recruiting for no less than 6 faculty again this year. But they'll be joining a group and an infrastructure that's set with leadership and is a very stable program. There's good and bad parts to both. I think everybody who came in early had the excitement of change and we're getting to this great place. But now I think we're quite a mature group. And what we really want to do are produce spectacular residents that's going to go out and do great things, really do substantive research, and continue to care for patients at the highest level. So just some data for you. These are our Vivian rankings, and you can see we did not start out well. And just by recruiting in better people, we dropped down to about average. But then it took a lot of work to get that down to where now we're, I think, 4th or 5th in the nation in terms of many Vivian rankings. You can see we had an infection problem that's been fixed. These are just a couple of examples of many quality metrics. These are our education programs, which have really flourished, and it's not just in the number of residents, but fellows. That fellowship number, I think, is outdated. We're to about 11 fellows this year. And as you can see, almost 40% of UT Houston medical students are now rotating through neurosurgery, which is very unusual number for medical schools. And I'll talk to you about how all of that happened. So, we could not have a great academic program without a residency. Teaching is really the heart of academic programs, and one of the things that helped our program immensely was getting our residency program approved in January of 2008. We had actually started the application even before I arrived because we knew that I was going to be in this job. And we were outside them, too late to go through the match that year, and we took 2 people that we knew. One was a UT Houston medical student who knew he was going into residency and I had met, and the other was a pre-residency fellow who was at the Brigham who we knew, and that was our inaugural class. And Yashua Eskenazi, as you'll hear later, joined us many years later and is on faculty. And Sean Miner, who was a UT Houston student, had an Air Force commitment, so he is serving his time in the Air Force. So we started at 1 resident a year, but I had always seen this as at least a 2 resident a year program. So what we did was we took 2 residents in the 2009 match, and we took 2 residents in the 2010 match. And our plan was to fill from below, so you keep adding 2 until you get to 14. Because taking transfer residents gives you residents right away, but there may be reasons why they're trying to transfer. So that's allowable under RRC rules. When you have a complement of 7, there's nothing that says you can't have matched 7 residents in your year 1. You just can't match anymore. That means you'd have 7s at each level. So we applied to go to 2 residents a year before we hit our complement of 7, and that was approved because by that time we were getting a huge increase in faculty and volume already, and that allowed us to keep hiring 2 a year for several years after that. So that's how we ended up going from, and that was probably the quickest any program has gone from inception to 2 residents a year. We were also on probation at that time because every new program is on probation for at least 5 years. And yet we still got the complement increase. In July, Arthur Day became the program director, and you're going to hear from him extensively and meet him. He is the most dedicated neurosurgical educator I know by far. He loves teaching residents, and he's had a chance to design a spectacular program from scratch, and it's put in a lot of elements that I think is terrific. You're also going to get to meet Spiros Blackburn, who is our associate program director and has been spending a lot of time with Dr. Day. He's a WashU graduate who did a fellowship at Emory and has just gotten a K grant and is just a spectacular faculty member. So in July, Art came and became our program director. After only 3 years, we got a full 10-year accreditation. And then even before we hit a full complement of 14, we decided to go to 3 residents a year. And we thought that would be the right number. Now that was after serious consideration. The more residents you have, the more diffuse kind of your experience with each faculty can be. And we decided 4 residents a year would be too much. But on the other hand, it was clear that with 2 a year, we were going to have many excellent cases and educational opportunities that could not be partaken by our current residents. So we initially applied to go to 3-2 and then 3 residents a year. So that's where we are now. By the time this class starts next July, we're going to have 3 PGY 6s and 2 PGY 7s. So that's the upswing that's happened. Next year, we'll have our full complement with every year at 3 residents a year, and we're going to keep that stable going forward. So how did we get such a dramatic increase in medical students into neurosurgery? I felt that was important for several reasons. I think we want this to be a teaching-oriented program and culture, and for that, everybody's got to be teaching somebody. I think that's a positive thing. We want our residents to be teaching students. We want everybody to be teaching nurses. We're teaching the residents. They're teaching each other. So, I convinced the medical school that neurosurgery should be a 2 or 3 week rotation as part of either their neurology rotation or their general surgery rotation. For general surgery, it's a choice, and something like 1/3 of the students are choosing to do some time on neurosurgery. And for neurology, it's not a choice, so we have a lot of students coming in, but we're not counting them as a full-time student. We're thinking of it as 2 weeks. So many of our students are having exposure. That's also important, I think, for our specialty to really show people what neurosurgery is, and we need to recruit the best students to keep our specialty vibrant. So you can see the numbers. We have a huge number of students on our service. In addition, we have set up many fellowships. I think you're all aware probably at this point what CAST is. Many hospitals are not accepting a fellowship as valid unless it's CAST accredited. And Dr. Day actually ran CAST for many years and was instrumental in setting it up this way. And you're going to hear more about that, but these CAST accredited fellowships are available to our residents that they can do as part of their training, so that our residents are coming out with a fellowship. And just to show you how they're doing, our emergency room gives out a award every year on the residents they like working with best. And our group has won this. We've had several residents win teaching awards from the medical school for the residents. So I think that's a big positive. So what about some of our graduates? We're a young program, and the very first 2 are Joshua, who's here, and Sean Miner that I described, and the next 2 residents were Shane Abdener there and Victor Lowe, and then so on down the road. We've had 3 people with Air Force or Army commitments, and if you take them out, we're currently running about a 50% going into academics and 50% private practice rate, which is quite high for such a new program. And of course, you can see I've hired a lot of our own residents. There are 3 here now. There was 4, but Victor decided, when he was doing his fellowship in Cedars-Sinai, he met a woman in LA. He was supposed to come back here on faculty, which he did, and then he decided to move to be with his fiancée. So already our residents are doing well, and the only message on this is I think our graduates are going to have enormous opportunity to do what they want in our career. This is what's happened on the research side. We have a huge expansion in research activity. We're currently spending, this is just extramural grants, but counting all monies, about $11 million a year in research, and there are very few neurosurgery departments that come close to that. We did this by raising a lot of money, and all of these labs were started with philanthropy. And I don't know if you're familiar with the Blue Ridge Institute. They rank every department nationally in terms of the numbers of NIH grants. This is 2 years ago data that's on the slide, 2018. We were 12th nationally, and in 2019 we jumped up to number 6. So we've been quite ascendant even in the research area. So let me spend a few minutes telling you about Houston. It's a very large metropolitan area. There's 2 medical schools, 3 residency programs. There's several large healthcare systems. Memorial Hermann is the largest, has about 25% market share in Houston. There's all kinds of insurance companies, and still a referral-driven city, and that is what helped us grow so much. We're much bigger than just the Memorial Hermann system should be on its own, and we started much smaller than it should have been. And so this system has 17 hospitals. It's about $6 billion in revenues, which is a pretty large system. And we the Misher Neuroscience Institute was endowed by the Misher family, a very prominent family that I've become very close to in the last decade, in 2005, and that was part of what made me want to come here. And so that's an institute that sits in our Texas Medical Center Hospital. We virtually fill a wing, and we currently have 141 dedicated neuroscience beds just on this campus, with 38 of those being neuro-ICU beds. We have 9 ORs and INR suites that we use, and all kinds of advanced technologies. We have a standalone children's hospital, but what makes that really hopeful is that it's in the same medical complex. It's just a different tower. So for coverage and residents, they don't have to drive somewhere. We did create a second rotation outside this TMC. It's the only one, and that's because when I trained, I had a really growing and excellent experience being the chief resident at the San Francisco General, where it really feels like it's your hospital to run. And we found a location that I think helps mimic that, and our residents really love this rotation. They go there, they're really the person, and we want them to think of that as a very independent experience. We're also a comprehensive program, as I've described to you before. As you get to know us, I think you're going to hear the word UTHealth Neurosciences. I just want to explain that briefly. We've integrated all of these different areas under one leadership now, so we're financial partners in a lot of this, and our group is quite cohesive and will lack turf battles and things like that exist in other places. So if you look at us by the numbers, it's now 170 faculty. In total, we have 113 residents and fellows, and 31 million in research. So it's quite a neuroscience powerhouse. So I'm going to go through this relatively quickly. You guys can always look back on it, but these are some of our faculty that you'll be meeting. And as you can see, it's a very large group of faculty. And I just want to point out the number of different areas of research where we have real strength and places that you can learn and opportunities for our residents. So what's an R25 program? It's a NIH inaugurated program that's been around for about 11 years. It's designed for the best programs to foster the academic development of trainees, and it's awarded on the basis of the excellence of the faculty, research opportunities, and this is kind of like a precursor to a K grant. So the NIH wants an academically oriented person to get an R25 grant during residency, then get a K grant, and then become independent and be R01 funded. So there are only 24 programs nationally that have this. And you can see, and some of them are just for neurosurgery programs, some are just for neurology, and you can apply as a combined program, which is what we did. And you can see this is a pretty rarefied company, and all the top academic medical centers have an R25 grant. You have to designate a list of mentors that can serve the fellows, and you can see these are different areas. Combination of both clinical scientists and neurosurgeons and neurologists and PhDs. So there's a wide range of choice. The other thing that we've done is created a research assistance program. Our two current PGY6s both have RAs. And so at the end of your research year, which is PGY5, you become a chief resident as a 6 and usually do a fellowship as a 7. And during that time, we want you to be able to continue the research you've done. And so we will ask for an application and then hire a RA who can be working full-time for you while you're back on the clinical service. And this is also good training for what doing research as a faculty member is like, because you generally don't have just blanket time in the lab. You have to juggle many things. A couple of other unique things about our program, maybe not unique, but unusual, is one, we have a whole leadership coaching program that we started with Dr. Bodine Orr. She's a physician coach and a management professor at Rice. And we start with resident meetings as part of their curriculum throughout their whole residency. This is not a punitive, you're misbehaving kind of thing, but it's a coaching program designed to help with leadership. You know, when we all went through, all of a sudden we found ourselves as chief residents. It actually is quite a management job, generally with no training and a lot of issues. And this has been taken very well by the residents. You can ask them. I think they find it very helpful. And learning to work in teams and manage other people and accomplish things that way is really the future. You know, the days of the lone wolf surgeon going off and doing whatever they want, those kind of days are over. We have a mission to Haiti that our residents go on. This had to be suspended because of COVID, just like the baseball tournament that we used to go to in New York, and hopefully those will resume soon. So for my last slide, you know, what do we hope you guys get out of being here with us for 7 years? That's what turns out. We first want you to be a very good doctor and then a superb surgeon. We want you to perform every basic neurosurgical procedure and get expertise, basic expertise, and then focus on an area of specialization. Now, I think having the breadth is very important because I think you all may be aware that the RRC is increasingly adding to neurosurgical minimum case categories. And there are many programs that can't meet the case minimums for certain areas. There's a lot of talk about how to rectify that, or residents flying around to get that experience, going to a different program. We do not have a single area, not one, where we don't have it here at home. But if you want to be good, even if you plan to go into, you know, community practice or spine practice, you need to specialize. And our program is designed after getting that base for you to be able to specialize and get expertise in a specific area. I think being able to work with people well is exceedingly important. And I know too many doctors who can't get things done because they just don't understand how they come across to administrators or other people that they need to negotiate with and so on. We are in a world of increasing performance measurement and regulation, and I want all of our residents to be comfortable with that up front and come out you know, able to achieve great outcomes. And for us as a field, I think innovation and advancing the field is very, very important. We do not have a set, you know, we want this kind of resident, whether it's an MD, PhD, or a full-on clinical person, or what we want is somebody who wants to be a leader in whatever areas that they are interested in, have a passion for it, and want to do something great. So that's it for me. I'm sorry for the little technical difficulty, and I'm going to turn it over to Dr. Day at this point. Thank you for your attention, and I really look forward to speaking with each of you.
Okay, let's go ahead and get started. This is Art Day. I'm sitting in my office. It looks like it's dark in my office, and it's partly dark because I just had a tripod fracture repaired in my face a couple of days ago, and my clavicle is broken, and my golf game sucks for the next few weeks, but I didn't want to miss this presentation today, so you'll have to put up with me a little bit as I'm going through this. But needless to say, we're delighted to have you here, and so I want to go over the details of this program. One of the spectacular parts of this program is its educational facilities, and so I wanted to make sure we got a chance to go through that with you. Okay, so this program here has been the culmination of my efforts of education for 45 years. When I got into neurosurgery, you didn't have to know much. You only trained for 4 years, and the evidence of what you had to learn, you could pick up by spending all night and all day, every day for 4 years in the hospital, and then you knew it. Obviously, we've gotten to be smarter about how to do that over a 7-year period with duty hour restrictions. And this is the culmination of my work and my own experience over the course of those years at University of Florida, at the Brigham, and here at the University of Texas, to about how I think the best way to train a resident to be the kind of doctor and faculty member when they're finished that they could be. And basically, the training program is what's called a 4+3 model. In the first 4 years of your training, every resident will have exactly the same training. You will learn all of the details of how to save a neurosurgical life, how to handle a neurosurgical a life-threatening situation, how to handle mass, how to handle CSF, how to handle blood, how to handle all the things that cause pressure and neurologic deterioration, so that when you are at the end of your first 4 years of training, called the core, you can take call on any neurosurgery service in the country. You can do whatever you need to do to be a neurosurgeon for your group. You know enough, and you know it well enough, and you have done it enough that you are sufficiently invested in being a good neurosurgeon by the end of year 4. Doing so then, while you're doing that in your core, you start your research preparations for the final 3 years, which belong to you. The last 3 years are individually directed, starting with your selection of your year of research, followed by a chief residency, then followed by a transition to practice, which invariably will include some type of fellowship that will be CAST accredited because of the sequence in which it's done. So if you reach the core requirements, then you will determine your last 3 years in a markedly accelerated way, and we'll see the effects of that over the course of time as we go through this process. The concept is based on the gradients that you need. And the gradients that I'm speaking about are knowing, first of all, the physiology and pathophysiology of the nervous system at a ground level. We start out heavily invested in acute care, in the acute care of head injury, the acute care of CSF problems, the acute care of stroke, the acute care of all the things that happen that you die from in neurosurgery. And as you begin that process, you then gradually expand that concept into going into the conditions of basic spine, then simple craniotomies for tumors, et cetera, endovascular, then more complex craniotomies, more complex tumors in spine. And then by the end of the 4th year, you are very proficient in complex spine, complex cranial surgery, and all the routines. At the end of that 4th year, then you will go to be in the laboratory at the site of your choice to do the kind of basic training or clinical training you wish to do, be it basic science or clinical science. And after you do that, you will come back as the leader of the service, the chief residency on a year. And then your last year will be spent as in honing your practice, getting ready for perhaps a postgraduate fellowship or your job where you intend to go thereafter. So how does that work? Well, the picture on the left shows you the gradient of how we design it for what you do year 1, 2, 3, and 4. And then the preparation on your right for your career. Everyone in the residency goes to the run course in PGY3 and starts a grant application process. As you get more and more sophisticated in PGY4, you will then prepare the choice of your research topic, submit a grant application and the R25 application for funding for that research. You will then do your research at PGY5, and then you will keep your laboratory open during PGY6 and PGY7. So you will have 3 years of laboratory funding paid for by the department, assuming that you are productive, in which you will be able to have a 3-year head start of your data and your project to be ready for being what you want to be when you finish the official residency. The 4 years of the core include the following. The first year is neurocritical care and acute care, all the PGY1. You will spend the time running the ICU, and working in the ICU and working in the acute care service to take care of all the acute trauma, all the hospital emergency cases that come in. So much of that time is spent in the operating room learning how to do a subdural, a burr hole, a craniotomy, a decompressive craniectomy for the acute care things that epidural hematomas, etc. You will then have a 4-month period of time where you will be a night float person during PGY2. You'll spend 8 months on spine during PGY2 and 3. You'll spend 4 months in pediatrics during PGY2 and 3. You'll have 8 months of cranial service ending in the cerebral vascular service during PGYs 2, 3, and 4. You'll spend some time as a night float, night ICU fellow, and then you'll manage cerebral vascular surgery in our Southwest Hospital during PGY4s. All that will be done. Each of you will have identical schedules. We will match 3 people from this year, and each of you will rotate to cover each of these years as a team for that particular year. The clinical services that you will work on are divided into 5 basic components and are led by either a chief resident or by our enfolded fellow or PEDS fellow. The 5 clinical services are the acute care service, in which a PGY6 chief resident runs it. There are a number of attendings. We have one of the largest acute trauma centers and spine trauma centers. We may be the first or second most busy spine trauma center in the country. So that team has a PGY1 on both the trauma team and the acute care team. It has several APPs, and it has a PGY6 running the service and the attendings that cover it. A second service is the skull-based vascular, which is responsible for open and endo. At our hospital, the endovascular services are completely within neurosurgery. All members in that department are in our department. We have neurologists and neuroradiologists and neurosurgery people dually trained doing endovascular, and a number of 3 or 4 open skull-based trained people here. I lead the skull-based vascular program, and we have Drs. Chin, Blackburn, and Cochran in the endovascular fellowship faculty, and a PGY4 resident, a PGY1 resident, a CV fellow, and multiple endovascular fellows on that service. We have a very large cranial service. We do more tumors by far than MD Anderson ever thought about doing. Primary tumors, these are primary tumors coming in. huge service, skull base and intrinsic primary tumors. That service is run by our PGY6 chief resident and has a PGY4 and a 2 and a 3 on service to run that service. Dr. Kim is in charge of that service with the tumor faculty. We have a composite spine program run by one of the PGY7s as they're refining their practice to get ready to leave the institution for their fellowship or their practice where they're leaving, so they will be independent on how to run a spine service or doing a spine fellowship, and they will have a PGY2 and PGY3 working with them. This service is led by Dr. John Caridi, who just moved here from New York City at Mount Sinai, and we have four full-time spine fellowship trained individuals on that service. And then we have a pediatric program headed by a pediatric fellowship in which you do during PGY2s and 3s, and we have 3 full-time pediatric faculty led by David Sandberg. So your core time will be spent on one of these services, and your PGY 6 and 7 times will be spent leading one of these services as I've outlined. This will be then sort of what your rotation would look like on a PGY year basis. Again, a rotatory basis with the core above the research and everything else down below. Now, as Don has talked about, when you go back to this slide, once you reach this line for the PGY4, then you should be ready for your own determination. And that's why this research here is so carefully planned in PGY4 and 3, because by the end of the 5, we want to be successful that the resident does get that aid of the research assistant. And we have finally reached that level this year. Both of our PGY5s reached that level. So now they're both our chief residents, and they both have research assistants working full time in their lab for the next 2 years during PGY6 and PGY7. One in oncology and one in functional. The one in oncology is now scheduled to go and do functional is now has a fellowship at Toronto, University of Toronto when he finishes. And the other individual who's in neuro-oncology is likely going to Sloan Kettering. So they already have their 4 years of organization established by the end of their 5th year and set to go to their desired direction. This is a place where we have to know stuff. Neurosurgeons should know what they're talking about. In our institution, every single resident takes the boards every single year until PGY5. If you take the boards every single year until PGY5, you will get a score. This score shows how many residents passed the boards before COVID started each year. This shows that 100% of the residents passed the boards every year. That means every 1, every 2, every 3, every 4, and every 5 passed the boards during their first year of taking it. You don't have to wait for 5 years to be able to get enough. You learn it immediately. The educational expectations are that you will be well enough to be able to make the board scores a passable grade by the end of PGY1, by the end of 9 months of PGY1. That's what that score reflects. This is our distribution as the program has evolved. About the red is the number of residents who take it. So obviously in this case, we'll have 15 residents who are 0 from year 1 to 5. So next year we'll have 15 residents who take the boards. We expect 15 residents to pass it because that's the educational program and the environment we have. We'll see some details about that. And the average board score per resident is well above the passing score. The average board score, including the average of PGY 1s, 2s, 3s, 4s, and 5s, is well over 500 for all averages together. Now we very, very strongly emphasize that educational benefit of this organized program with a core, and we supplement it with the exposures of what you have to do to make sure you know how to take care of patients acutely. There is some time for nighttime in-house coverage. I've already talked about that during PGY2 and PGY3, but we also have a full-time night PA in the hospital with you Monday through Thursday. And basically, you will not take any call in-house or designated in-house after PGY5s. You will have to take a little bit during PGY5s on every other week. Every third week, you'll have to take 1 day a week for in-house call to make sure the chief residents get some time away from the hospital. We have 3 long-standing PAs that work on our service to make your business day much better, that will help take care of discharges, help take care of the busy work that needs to get done, the scheduling, things of that nature, to make sure you have much more time in the OR and to do the things you want to do for your educational benefits. We have a educational program every morning of the week. We're in a single hospital, so all of the residents are together every day, with one exception of one resident being out at the Southwest Hospital. So by the time you're here, we will have 20 residents who get together every morning to go to conference. And on Monday, we have a rotating yeoman's review. On Tuesday, we have a curriculum conference that I lead, talking about neuroanatomy and neurophysiology. On Wednesday, we have a cerebral vascular conference. On Thursday, we have a combination of M&M neuroradiology and grand rounds, the chairman's conference. And on the afternoon, we have a journal club, a skull-based dissection laboratory, or a neuroradiology teaching course. On Friday, we have a spine conference. The OR start at 7 or 7:15, but the residents stay in conference until 8 o'clock, so they don't have to leave. So the process then works well for them to be able to get an hour of education every morning before they have to go to do their work. And when you're on various rotational services, you also will participate in leading or going to tumor board, the neurotrauma conference, the epilepsy conference, or the pediatric neurosurgery conference. So these are our residents. They're from around the country. It seems like, I could say the process here does not include our last 3, but we've matched well, and then the 3 more for you. Here is the schedule of where we will be happening after I'm finished here. Today we gave you the introduction and overview of the program and the educational venues. We're going to break in just a few minutes to go to a series of 20-minute interviews. And then when the interviews are completed, the faculty will leave and you will be invited into a chat room where the residents will be waiting to answer any questions. Normally we would we would take you out to dinner with the residents and let you get to meet them without the encumbrances of faculty around. So this is our best way of doing that in the COVID environment. So it really is an honor for us to have you here in this format. And any of you, if you have any questions after you go through this process, if you have any questions, can communicate with me directly. Or go and look at the presentation on the website to make sure you fully understand it. It really is, like I say, a model program that has grown exponentially. It has been a happening event over the course of the last few years to reach its current state. And finally, Houston is a spectacular place that I certainly didn't miss the cold when I left Boston, and The athletics are not quite as good as they are somewhere, but we still have some great things to do here. And Houston is a really fun place to live. You're looking now down at the largest medical center in the world. That's what we have here at the University of Texas, Houston. So I guess now I need to sign out.